So the history of bias in healthcare. The history of AI bias actually is it's not a new concept. As early as the 1970s, Weizenbaum's book, Computer Power and Human Reasoning, suggests that bias could arise from data and coding assumptions embedded in computer programs. In 1982 is the first documented example of algorithmic bias, specifically in admissions decision making, and it resulted in discrimination against women and ethnic minorities in being admitted to medical school. That particular example actually happened in the UK. So good to know sort of the history of algorithmic bias. In 2019, and I'll talk a little bit more about Obermeyer et al.'s finding, where an algorithm perpetuated racial bias without even calling out race in the development of the model. And more recently, New England Journal of Medicine, which has questioned in clinical decision support that may not even be AI specifically, but some of our more rules-based algorithms, the use of race in perpetuating inequity. So bias really is systemic error or deviation from ground truth, and it can occur at each stage of the AI lifecycle, from problem formulation. Who gets to decide what problems are worth utilizing our AI resources? Are we at risk of focusing on diseases that are prevalent in affluent populations and paying less attention or spending less resource on AI-enabled solutions for those diseases that are more rare or less affluent populations are inflicted by? To data creation, how data is acquired, the model development process. Decisions are made by data scientists throughout the model development process, and that can amplify bias. During evaluation, there are steps that you can take to evaluate the performance of a model by subpopulation. Sometimes developers will not or bypass this and assume that every patient is the same and that the model would perform equitably without checking if it in fact does perform as intended in subpopulations. And then deployment and maintenance, because ultimately what we're trying to improve is outcomes. And so are those outcomes achieved across demographic groups? So one case study of AI bias detection and mitigation is in a population health risk model. We talked about risk stratification and using biomarkers for risk stratification. In this particular example, it was for detecting risk of disease progression in a chronic case management or chronic management condition. The problem was that in selecting the proxy for ground truth, it's not like there is a column in your data set that says high needs or high risk or sick, but that developers may select a proxy. And in this case, the developers selected a proxy of healthcare utilization as a proxy for healthcare need. And it turns out that healthcare utilization, at least in the United States, that Black patients have a lot of barriers to access that result in lower utilization of healthcare while being equally sick. And so the model that was developed and deployed exposed over 200 million times was actually amplifying an inequity that systematically systems-wide existed. And so this particular model had such an impact that the researchers noticed on a national data set a drop-off, an unexplained drop-off in case management referrals to Black patients. And it was only when they retroactively looked at the model that they were able to pinpoint that the cause was this particular model and the way it had been developed. The solution was actually quite straightforward. Instead of using utilization as a proxy for need, they actually used what clinicians used, which is whether or not patients have actual disease, diabetes, hypertension, diseases on a problem list, and whether or not they were controlled. So that simple switch in the proxy for healthcare need was able to rectify the model and make it fair for both Black and white patients. So bias mitigation methods, fortunately, there are really good methods to mitigate bias that can be applied throughout the AI lifecycle. There are a series of best practices for responsible AI in healthcare, including the organizational structure, that problem formulation, ensuring that there's clarity in how decisions are made in terms of which problems to address, the algorithm development process, evaluating the model performance across subpopulations, and then making sure when it's deployed that you're continuing to monitor over time. Examples of technical techniques for bias mitigation, specifically within AI modeling, include toolkits such as Equality ML Toolkit, which is out of Microsoft, FairLearn. There's a number of toolkits that specifically help developers, AI developers, do subpopulation analysis of performance, detect if there's bias, and mitigate that bias. The challenge is, just like in any kind of innovation, is actual adoption of technology and tools that are already available. So one way that we can amplify the ability to implement these technologies is using automated AI monitoring technologies. And there are a handful of academic medical centers, both in the US and in the UK for that matter, that are beginning to develop these automated AI monitoring systems. So it's less of a, say, anecdotal developer decision-making process or a human AI governance process, but baked into an automated AI monitoring system. So one of my colleagues at UChicago Medicine, Brett Beaulieu-Jones, has developed a prototype where this automation of AI modeling evaluation is done throughout the AI lifecycle. Ultimately, most importantly, in the outcomes area, because that's really where we want to make sure that there's equity, or at least not widening disparities when we deploy these models. So there are over 200 responsible AI frameworks. This is just one example of an responsible AI framework. In general, they cover 6 main areas: making sure AI is robust and reliable, that we're respectful of privacy, that it's safe and secure, fair, transparent or explainable, and that there's or a system of responsibility and accountability. Rooted in these responsible AI frameworks are principles. And ultimately, here in this particular article, it's distilled into 5 principles, but ultimately the main principle is healthcare as a human right. And so as we deploy AI in healthcare, assuring that we really are building systems where healthcare is respected as a human right, and that therefore everyone benefits. After those frameworks, there are a number of standards. And so all of these standards actually incorporate core principles around responsible AI. International standards include ISOs 42001. Here in the United States, we have national standards, including NIST's AI Risk Management Framework, which is agnostic to, say, health, to any particular vertical. And then industry-specific standards proposed by National Academy of Medicine. There's a coalition called CHAI that's also proposed some healthcare industry standards. And then layering on AI regulations. So in the US, there are definitely, FDA continues to have some regulatory authority over a certain subset of AI models. And then certain states have started to develop some regulation around AI use in healthcare. That can be quite burdensome. Here are some examples. So UChicago has a wonderful, easy to use algorithmic bias playbook. It's written at sort of a lay level where most can understand the problems as well as approaches to mitigate bias. The AI risk management framework, as I mentioned, in the ISO 42001. But the healthcare systems that do this really well have invested millions of dollars in developing both the infrastructure as well as the talent. They have access to the talent in order to effectively govern. But what does that mean for healthcare systems that don't have access to a huge amount of talents like data scientists, faculty members that spend their entire careers on ensuring effectiveness and monitoring. Are we entering into this era where, especially with deregulation in the United States, where you have some institutions that are well equipped to govern the effective and safe use of AI and other health systems that are not? The vast majority of care in the United States is delivered in community health settings, not in academic medical centers. And so my colleagues and I have proposed right-sizing AI governance by institutional capabilities, what we call HARA, which essentially right-sizes depending on an organizational's maturity. So for most community health systems and above, we argue that having at least a level 3 level of maturation. For some health systems, they're at level 1 where it's ad hoc. They really are just accepting what the vendors tell them about products, and they have very limited IT capabilities. Often these healthcare systems don't have the treasure, they don't have the talent, and they don't have the technology in order to effectively govern. But at the very least, moving, say, from a level 1 to a level 2, where there is an oversight, there's some structured needs assessment, there's basic evaluation criteria that's utilized, especially even as they navigate vendor contracts. We also call for a responsible AI community partnership model where academic health systems or those health systems that have resources and capabilities create collaborative models with community health systems, those that are under-resourced. This is one of our areas of research, comparing a community hospital with a large academic medical hospital and testing 3 different models for local validation in both systems, as well as an AI governance framework within a box, disseminating that information from one health system to another. There are examples, at least in the US, of similar type of collaborative models within the electronic medical record, where some health systems will, almost in a managed services kind of capability, share or provide IT services, electronic medical record services, for community hospitals and federally qualified health systems. So with that, I would say we each have a role to play to ensure that the future of AI is in healthcare is effective, safe, and benefits everyone. But there are a lot of challenges. Each of us as health excellence champions have a role to play to making that future possible. And one I would say is making sure that AI governance is a high priority, that if you're a clinician, if you're a researcher, that you know that there's AI governance in place in your organization. And if there is, ensuring diversity of stakeholders, including community members, in that AI governance process. That diversity of stakeholder engagement has been found to probably be one of the most effective human interventions when it comes to decreasing the risk of AI bias. And then measuring during that validation across subpopulations, ensuring the models actually work for everyone, and then any kind of disparity gaps driving innovation and policy. So I end there, ensuring that AI advances healthcare as a human right. Thank you.